Well, hello there again. Welcome to really the last lecture in Therapeutics 1. This one is on non-invasive positive pressure ventilation. What you're looking at here is an iron lung, which is a form of non-invasive positive pressure ventilation. One of the things about MPPV or NIPPV, depending on what you're reading, what you're looking at, is that you don't have to be intubated, nor do you have to have a tracheostomy in order to be in these devices, okay? So this is just sort of a indication of what happens on occasions, okay? People who have sleep apnea, their spouses or their significant others sometimes make a great deal of difficulty for them and they're trying to get some sleep. A lot of times what happens is they'll roll them over, push them over, do something else with it. How do you know that a patient or a person has sleep apnea? You're going to talk about this when you get into advanced pulmonary diagnostics. But one of them is that they snore loudly. And it's one of these snores that you hear throughout the entire house. And sometimes folks go, I don't think I snore. And people are going, oh, yeah, you do. The walls are vibrating as a result of it. So at this particular point, this is just showing you that you finally get to the point where someone says this has to give. Either you get treatment for it or otherwise we get separate rooms. So non-invasive positive pressure ventilation is NPPV or NIPPV. It consists of continuous positive airway pressure, which is CPAP, and we'll talk quite a bit about that. It also consists of bilevel positive airway pressure, and this is your BIPAP, okay? And these are the major two parts of it. The other thing is your positive and expiratory pressure, which is PEEP. Remember, we all have PEEP in our airways. We have about 5 centimeters of water pressure in PEEP. Helps keep the alveoli open, keeps them from collapsing on us. And we still also use PEEP for these non-invasive ventilation. So the question is why do we? Well, in this case, what you're looking at here is basically the closure of the airway. Originally, when we had CPAP, it was there for sleep apnea. People were put on it to try to keep the airway open. If you look at the top picture a little bit, let's see if I can get my marker here, my pen. When you look at the top picture up here, this is an open airway up here. And here's someone's airway that has collapsed. And in this case, they're not exchanging gas. And so what happens with that, when that airway closes, they're like, and they're not breathing very well. And then all of a sudden, it's like they kick out of it once the airway is open. So we use CPAP to be able to do that. Basically, they could also use a nasal mask to rest muscles for neuromuscular disorders. And basically, we've also used it for patients who are in acute respiratory failure. It helps them be able to breathe and keep the airways open. So why do we use them? What's really, really good about these? Because we use them for reasons other than sleep apnea now. We actually have CPAP on our ventilators, but it's there to improve oxygenation, okay? So CPAP's main goal in life is to improve your oxygenation. People who have sleep apnea, when they're doing the sleep apnea testing, they keep track about how low their SATs drop. Some of these guys drop down into the 70s and things along that line. And then once they start breathing again, then they'll get back up into the 90s. There's also others that need to be on oxygen while they're on their CPAP machines because they actually do drop so low that they're concerned about the effects of the hypoxemia on them. So it keeps the airway open, and we adjust this for patient comfort. One of the things, and I'm going to talk a little bit about it later on too, a little bit more, is that this is not a device you go in and say, okay, we're ready to put your CPAP on. It's going to help you quite a bit. You're going to be able to breathe better. It's something that we sometimes have to convince our patients to wear. And there's PEEP that's used to keep the alveoli open. It also improves oxygen because it allows better gas exchange to occur because we're not getting rid of the gas all at once and collapsing the airways at that particular point. And so we have a physiological peak of 5 centimeters of water pressure in our lungs, as I mentioned earlier, and that is there to help us keep those airways open at that point. So the question is, well, how does it improve oxygen? Well, CPAP and PEEP basically increase your FRC, okay? And the way it does it, it recruits alveoli. So what do we mean by recruiting alveoli? Well, what it does is as the gas enters into the lungs and into the alveoli, that gas actually is able to leave the alveoli it's in and through the pores of Kohn and the canals of Lambert go into other alveoli. And as a result of doing that, what happens? So anyways, once the gas exchange has taken place, what we're doing is we're bringing more alveoli online, and therefore we're recruiting them. And as a result of recruiting them, we increase our FRC, and when we do that, we get a better gas exchange, and that's why we improve oxygenation. It also decreases the work of breathing. When you have collapsed alveoli, you have to work harder to be able to breathe because you're only breathing off a limited number of alveoli. Once you start opening the other ones up, it makes it much, much easier for you to breathe at that particular point in time. So BiPAP, bi-level positive pressure ventilation, actually has 2 levels. One is IPAP, inspiratory positive airway pressure, and the other one is EPAP, expiratory positive airway pressure. We set 2 different levels of pressure. What I should have mentioned with CPAP, you have one level the pressure goes in, and then you exhale against that same level or same pressure. With BiPAP, you have a higher input and a lower expiration at that particular point in time. So we use IPAP to improve ventilation, and we're doing that because when we go ahead and open up the alveoli, now we're able to have better gas exchange again, and in this case, we're going to be able to remove some of the CO2. EPAP is improving oxygenation, has the same effect as CPAP and PEEP does because it keeps the alveoli open and allows that gas exchange to occur, and then the oxygenation gets better at that particular point. So the question is why do we use them? What is the purpose behind it? We knew that CPAP was for sleep apnea, but what are the other reasons that we use it? And one is to prevent intubation. If we have patients who have an asthma exacerbation, we have patients who have COPD, they don't want to be put on ventilators. We have patients who are in the active process of dying. They don't want to be on ventilators. They want to be comfortable until their family arrives in some cases. And when that happens, we're able to go ahead and put them on CPAP or BiPAP and make them comfortable until their family or loved ones arrive and they're able to say their goodbyes. So there you see DNR, COPD, asthma is another one. And then sometimes post-operative respiratory failure. These guys are not able to breathe extremely well. We want to go ahead and not put them on ventilators. We want to keep them off, and we'll try the BiPAP or CPAP at that point. Also, if we're in the process of trying to wean a patient off a ventilator, we know the patient's weak, but they need to be off the ventilators. We'll sometimes use CPAP to help us with that. And then there's nocturnal hypoventilation. This is kind of an interesting one. This is Odine's syndrome or Odine's syndrome. Basically, it's based on one of the goddesses. Her name was Odine. She went ahead and she came to Earth and she met this mortal man. She was a good-looking goddess. He was a very handsome man. The two of them got together, got married, had a couple of kids. She wasn't quite the goddess that she used to be, and so her husband went out and found someone else, and she caught him in the haystack with this local girl, and she basically said, I'm not going to kill you, however, when you go to bed at night, you're not going to be able to breathe. Sadness. And so we have people who have this problem, and in those cases, we have to use CPAP or BiPAP for them. So not everybody who can meet the requirements of CPAP are really good candidates for it. As I mentioned to you a little bit earlier, we have to talk these patients into it. And sometimes we're not only talking the patient into it, we're also talking the patient's family into it. So people that we are able to put on CPAP or BiPAP right away have to be what we call awake and alert. Okay, you're not going to do this to someone who's unconscious and not able to follow through. So they have to be able to at least have some response with us. Their airways have to be protected, and they're the only ones who can protect them. You have a lot of pressure being blown into the airway. If you can't manage your secretions or manage or handle your your airway, period, then you're not a good candidate because you're going to end up with aspiration pneumonia and some other issues. And so we need to make sure that you can do this. You have to be able to tolerate the equipment. Now, a lot of times in the hospital, we're using masks. We have nasal masks. We have some of the facial type masks that we use. We also started to use helmets, and I'll show you a picture of a helmet further into this. Patients who use CPAP at home or BiPAP at home sometimes have what we call nasal pillows, and if they don't bring their equipment with them or they can't bring their equipment with them, we put them back on a nasal mask, and they complain because they're not comfortable. They're not used to wearing that equipment, and we can run into problems with that. Conscious, cooperative, and that includes the family. You have to have this family being able to say, okay, this is a good thing. Mom, dad, whoever's okay at this point. So we're going to be, let them be comfortable with it. If you can't convince the family, you're not going to be able to convince the patient. And in some cases, we have to give them a nasogastric tube. If you think about it, when air is being blown into you, it doesn't all go to the lungs. Also, some of it goes to the stomach. And so what happens is the gas that's going into the stomach can collect down there, cause the stomach to distend. Once that happens, these patients will start to vomit or have other issues, GI issues at that point. We're pushing up on their lungs, and they're defeating the purpose of why we're using this equipment in the first place. So there are people who will not make it, okay? If a patient has apnea, okay? If we're talking about someone who has short periods of apnea, 4 or 5 seconds or something like that, yeah, that's sleep apnea. We can handle that. If you're talking about a patient who's apnea and not breathing for 10, 15, 20 seconds, that is not a good candidate. Those guys have their apnea periods are way too long. If you have someone who is coded, who's a DNR, they're not good candidates. They're not alert, awake, or conscious. If their blood pressure is all over the place, if their heart rate is all over the place, if we put them on this equipment, we're going to continue to cause that problem to happen and get worse. And so we need to make sure that these guys are stable. Their blood pressures are stable, their heart rates are stable. Facial burns, if you're having a face mask on, you cannot put something over those burns. If you want to be killed by the physician, try it. Same with facial trauma. They're unable to protect the airway, manage their secretions. And then if there's anatomical abnormalities that tell us that we can't use this, okay? And another one that we see is if the patient needs to be intubated, they need to be intubated. We don't do a stopgap method to try to say, well, listen, before we intubate them, let's go ahead and try this. If they need intubation, they need to be put on a ventilator. So with everything else, there's reasons why you can absolutely not do this, okay? This is someone who's in a coma. They have cardiac arrest, respiratory arrest. These guys are not alive in some cases or barely hanging on. This is not a stopgap measure for them either. and there's your mechanical vent. Okay, so those are reasons why we don't do those. How do we start? Normally in the hospital, we're going to get the settings from the physician. If it's somebody who's had a sleep study and they use CPAP at home, if they bring their equipment in, if the hospital allows it, now we're not, a lot of times, not allowing that to happen. Then they have to tell us that my level is 12, my level is whatever, and we'll set the level to match what they have at their home at that particular point. But if you're just a patient in the hospital and we're going ahead and put you on this, then the physician's going to come and tell us where he wants to put those levels. Normally with CPAP, like I said, they can tell us it's 12. That means you have a 12 pressure going in, and you're breathing, exhaling, or breathing against a 12 pressure when you exhale. BiPAP, remember, has two levels, IPAP and EPAP. IPAP is always higher than EPAP. If they're set the same, it's CPAP. But if it's like, for example, you see here 12/5, that means we want an IPAP of 12 over an EPAP of 5. We're going to use the 12 centimeters of water pressure to push the pressure and the gas in. And then we're going to go ahead and exhale against 5 centimeters of water pressure. And that's your EPAP. So normally we start around 8/5, and then we're going to increase them in increments of 2 to 3 centimeters of water pressure. And it depends on what we're trying to do. If this patient has a lot of CO2, in some cases, if their oxygenation is okay, what we'll do is say, okay, let's go from 8/5 to 10/5, or let's go to 12/5, okay? If there's an oxygenation issue, then we can go, let's bring that IPAP up to 10, and let's bring that EPAP up to 7, okay? Why did I go up on the IPAP? I went up on the IPAP because I'm still getting rid of the CO2, all right? But I have to bring up the EPAP to take care of the oxygenation portion of it. And as you can see, we're going to titrate this for the patient's comfort. When we set these up, we always set the equipment up, make sure it works. We're going to let the patient feel how much pressure and flow is coming out of it. And then sometimes these patients are like, you've got to be kidding me. It's a tornado. You're giving me a tornado to breathe against. And we're going, no, you just need to relax. It's going to be okay. No way. And so instead of starting at 8, we'll sometimes lower it to 6. And then we'll see if we can get them to start at 6. If they can't, we'll have to lower them both to 5. EPAP in some cases does not go below 4, and neither does the IPAP, and we'll just bring it down to that level. And then if we can at least get them to put it on, feel how it feels, make them comfortable with it, then we can start to increase those numbers closer back to where the physician ordered them, okay? In some cases, your physicians will call them and tell them, hey, we have Mr. Jones on CPAP, BiPAP right now. Your order said 8/5. He's at 7/4. Is he comfortable? Yeah, he's comfortable. He's sleeping. Just leave him alone. You know, at least he has it on. And that's what we need to worry about. And there it is. We want to make their respiratory status better, cardiovascular status better, and along with their neurological output. We want that good too, because at least they're resting and they believe they're going to get better too. This is an old machine. This is a BiPAP ST, spontaneous time. You may see these in some places, but we normally don't use them anymore. You can see the circuit looks a little bit old here. It's not clear. Sometimes the home care circuits are a little on the grayish side, simply because it's gray tubing. In the hospital, our tubing is most of the time clear. And then we had this older mask, not very, very comfortable. This little piece up here would help us to secure the mask between the the upper portion like here, and then their forehead. And it worked out really, really well for those patients. And what we had was a monitor down here. This portion of it was also on the back of this machine. So we could set it on the back, and that way people wouldn't play with it. And then this gave us our pressure, so we could monitor the pressure the patient was receiving. We could monitor the vitals, their tidal volumes, things like that. Make sure that they were doing okay as far as that goes. On this machine, if you wanted oxygen, you had to blow the oxygen into it. You had to use another piece of tubing to be able to put the oxygen to it. And sometimes what we would do is we would put the oxygen back here. We'd put a bacteria filter in this area, and then we'd have a like a not quite a T-piece, but close to a T-piece, and this is where we would put the oxygen for that patient. The other places you would see people doing it is they would sometimes put it on the mask, and then we just blew it in on their face at that particular point. Not necessarily comfortable. And this is what the back looked like. You had spontaneous, here's your IPAP, your EPAP, and there was no, you could set a backup to it at this particular point. Over on this one, over here, there was really no backup, but this is your backup. And then we were also able to control the timing of how long we wanted the patient to be in inspiration. At that point, we really don't do that much anymore. This is a new one. This is the BIPAP Vision. This is like the intermediate, if you want to call it that. We used this quite a while. On this one, you could actually hook up to oxygen. You can see the head strap in this case, and here's the face mask, the nasal mask. At that point, here was what we called a whisper valve. The whisper valve, when people walk by, they go, "You got a leak." And we go, "Yeah." Don't cover that leak up, because that's where the patient exhaled. So you always had to turn that away from the patient so that they weren't getting it blown back on them at that particular point. So at that point in time, this mask did not have a whisper valve incorporated in it, and we needed to make sure that we actually put a whisper valve with it at that point, okay? On this one, all your settings are up at this particular point. Your oxygen level was up here. Like I said, you could hook this up to oxygen at that point. This told you about your alarms, where you needed to fix them. You had your pressures, your tidal volumes, all of the different things that we could monitor in the middle of the screen. And these were where we set the settings at that particular point. So the question is, what are some of the complications that go with this? And one that really that we had to be careful of, because we also had to watch this when we had patients who were intubated, is facial tissue damage or trauma that we would cause. And we would cause it because sometimes people would over tighten the mask on the patient's face and cut off circulation to their face or to their nose or things like that. So we always had to watch that. Lots of gastric distension. We had to get rid of that. So mention people have vomiting that was going on, or other things that were happening as a result of this. It was the stomach was pushing up on the lungs, making it difficult for them to breathe. So we'd run into problems. Now, one thing you need to remember is if somebody is wearing a mask and they vomit into that mask, because we have full face mask, they can aspirate before we ever have a chance to get into the room. So we do have to be careful with that. Blowing it in your eyes was not a really cool thing. Lots of sinus pain and congestion because we're blowing it up your nose, and it's drying also. Oxygen is drying, and this gas, although not oxygen in some cases, was very dry also. And so we need to add humidity to try to prevent some of that congestion that was happening with these patients. And then if we set the settings wrong, we cause hemodynamic instability. We cause their blood pressure to go all over the place and their heart rate to follow along with it and cause some problems. So different interfaces that we had. This was sort of like your nasal mask, and you can see these two little things right through here. This is where people used to hook up the oxygen when they blew it into the face mask, either side or both sides in some cases. The nasal pillows. You can see this one has a chin strap on it over here. Patients have to keep their mouth shut. Otherwise, what happens is the air goes in through their nose and comes out their mouth. and doesn't make it down into their lungs. And then this one is a full face mask. It actually covers the nose and the mouth. We still like to have them close their mouth because if they open it, sometimes they can misplace the mask and we'll run into problems with it. You still have your head straps at this particular point, just a little bit different. So there's a nasal mask, nasal pillows, full face mask. Mouthpieces, newer ones are out there, and then the helmet. And this is sort of a representation of the helmet. There was a movie, I Come in Peace, I don't know, Dolph Lundgren. I'm not sure if you guys ever saw that, but basically that's what that looked like. So how do we do it and what do we do with these? We just start CPAP, BiPAP. Always have to check the orders, always and forever, okay? Got to make sure you have the right patient, understand what's going on with them. And then you're also going to check and see what else is going on with this patient. Sometimes physicians will write orders and then something will happen between the time that they write the orders and we get the orders. Patient could have had a stroke, they could have had something else that happened. So we always want to make sure that we understand what's happening with the patients, okay? And sometimes it's nice to have somebody help you. Sometimes if you haven't set up the BiPAP machine or it's a new one or the CPAP machine for 5 or 6 months, sometimes you're sitting there going, oh yeah, I remember something, but don't ask me what. And so sometimes it's good to recruit some help for you. Always talk to your patients. Always explain to them what you're doing, why you're doing it. Be positive. Be positive, okay? I cannot stress anything you do. You have to either be very neutral or very positive, but you can't be negative. You can't go in there and go, oh, it's going to be really uncomfortable. You're going to blow a lot of gas into your face, may get into your eyes if we don't fit the mask right. That facial strap, it may feel really, really kind of bad too. So, yeah, whatever. Don't do that. Please don't do that. That is the worst thing in the world because that patient, you just told them, don't bother with this. You're not going to wear it. It's not going to work, okay? And if they need this, we need to be sitting there going, this is going to help you breathe better. It's going to help you relax. It may help you get some sleep. We're going to work with you, make sure that this is comfortable. That's one of the main things we need to do is we're doing this for your comfort and for your welfare. And then we're going to measure because the masks come in different sizes. People find it hard to believe, but most people with their noses are somewhere between petite and small. You may have a small with a wide nose, or you could have a petite with a wide nose. People say, well, I'm 6'2", I have to wear a medium mask. A lot of those guys are small masks too. So it's just based on the size of their nose at that particular point. So this is, like I said, this is a picture of the same thing. Here's your older mask at that point. So we're going to let the patient see it. Some patients, if they're at least awake and responding to us, we can let them hold the mask, see what the mask looks like. We can turn on the parameters, show them what or let them feel what the pressures are going to be that we're delivering to them. And if they tell you that's a little bit too much, okay, we're going to titrate a little bit down, turn it down just a little bit, make it comfortable for you at that point. And then, yeah, that's so much better. Thank you. And then at that particular point, then at least we have them having the mask on, okay? And hopefully helping them, okay? So we're going to check, make sure it's comfortable for them. Check for leaks. Remember, you're going to have gas blowing out of that mask a little bit, and especially out of the whisper valve. So you need to make sure that you feel something, but you don't want to feel all that pressure going out, okay? And then you're going to use, once you get the head straps on, you're going to put 2 fingers, as long as you can put 2 fingers between the head strap and their face, then that mask should be loose enough, okay? Or tight enough if you want to look at that. And of course, you're going to have to document, okay? Document everything, the date, the time, the pressures, the size of the mask, level of comfort, any oxygen setting, pressure settings, anything else, their respiratory rate, their blood pressure in some cases. We can do their tidal volume in some cases because we can measure those. Everything about the patient has to be documented. You know, if their patient's orders were 8/5 and they're on 7/4, we need to document, and also document in there that we had told the physician and the physician agreed with it. So we need to make sure that we do good thorough documentation. And this is a patient, okay? In this case, this is a very big lady, and she doesn't hardly have a neck, and that she may, in fact, have sleep apnea. One of the things is sometimes with the patients that are really big and have no neck, instead of being able to use a nasal mask, sometimes we'll actually trach them, and their CPAP is run through their trach for them, okay? And then should be another picture. There it is. This person, you can see, not quite as big. However, if he's getting sleep, he can probably shave very well in the morning and do very well with it. Normal CPAP, BiPAP patients are anyone who has a problem, okay? One of the folks that used to be a student, her husband was like 6'2" and weighed 180 pounds, and he had sleep apnea, and he had to be on a CPAP machine. The youngest patient that we heard of being on some type of CPAP was like 3.5 years old, and the person who worked with her was able to get the child to wear the equipment and do quite well with it. Now, one thing too, and this is something that you need to think about, and if you're working in home care, this is especially important. Patients who have CPAP, BiPAP, their home care companies change out their equipment either every 3 months, 6 months, just depending on what the contract is. And we need to make sure that these patients, in fact, are doing that. One of the folks' stories that we heard was this gentleman actually brought his wife in back to their home care provider, and he said, I can't use my machine. Every time I use my machine, I'm getting all these sinus infections. And, you know, my wife is here. She'll testify to that. And she goes, yeah, he has lots of problems with it. So he's not able to do it. So they called the company, and the company basically said, well, he hasn't had a change of his equipment. He hasn't asked for a change of his equipment for the last 8 or 9 months. And if you were to look and open up that circuit, you would see a lot of mold in it. And that is exactly what had happened is because they were using heated humidity, which they needed to use. And the fact that he had not changed his circuit allowed that mold and mildew to actually grow in that circuit, and that was causing all of his sinus problems and everything. So if you're working in home care, you always want to make sure that these patients change their equipment when they're supposed to. Make sure that they're supposed to stay safe at that particular point. And this is the V60. This is one that when you go to clinicals, you may end up you may see it. Nice push button, almost like a video game in some cases. You put all your settings in here, and then you just come up here and you see all these settings, and there's your pressure limits and everything. Hooks up to oxygen. Here's our pressure line over here. Here's the clear circuit. And these circuits are designed for the CPAP, BiPAP machines. These are not circuits you're going to find on your mechanical ventilators, and they're really not circuits we're cutting from the blue tubing. There's a different inside. It's a whole lot smoother so that the gas doesn't have much interruption with it. So you can come down here, make your changes, and then you can come up here and just run your finger around this, and that will change it for you, and press the button and it sets it for you too. So that's a new one that's out there. A really, really nice machine to handle.